Yeah, no, I think so. There's many reasons for this. So let's talk about the most basic reason that artificial intelligence in echocardiography can be helpful in the diagnosis of cardiac amyloidosis. Cardiac amyloid, or amyloid in general, is a condition that is fairly difficult to diagnose. The clinical signs of the disease are fairly nonspecific, and so it takes a while for clinicians to realize that their patient might have amyloidosis. In fact, it is frequently encountered that it is the cardiologist reading an echocardiogram who first notes that there might be infiltrative heart disease, and they start thinking about amyloidosis. Yet, even though we feel that we're picking it up early, it's not early at all. It takes many years of amyloid deposition within the left ventricle to make the ventricle thick and for patients to develop those signs that we're talking about. So by the time that the disease is manifesting on an echocardiogram, a fair amount of time has passed by, and the patient has developed a fair amount of disease that is often imparting a fair amount of morbidity. And so I think at academic centers, I think we may be more attuned to the diagnosis, and we're paying close attention to these echocardiograms. Certainly we are at City of Hope. But across, I think, if you look at the world at large, very high numbers of echocardiograms are performed, and people are not always looking for an esoteric disease. And so I think a lot of more subtle findings of cardiac amyloidosis can go missed. And so I think this is true for a lot of the less common diseases that people are not always looking for. So if you have kind of an overreader, per se, that's constantly kind of watching over these echocardiograms, it can catch things that sometimes we just naturally miss as humans. And so that's kind of the fundamental baseline, I think, help or support that AI can provide. But taking it a step further, I think one of the challenges we face in the amyloidosis sphere, and those of us who are focused on this disease, is identification of patients earlier. So sure, if you have AI, it might detect it when a human doesn't. But what about even when we have people who are specialists who are looking at these studies, and we can definitively say that we're really not seeing clear signs of amyloidosis. We want to be able to pick up the disease earlier than most of us who are specialists can pick it up. And the reason for this is that so there are two main forms of amyloidosis. There's AL, which is light chain amyloidosis, and transthyretin, which is called ATTR. So it is now known that roughly 15% of people who have HFpEF and about 16% of patients with aortic stenosis have these conditions as a consequence of underlying ATTR. If you think about the population of people who have heart failure, and half of them being heart failure with preserved EF, it's a very large part of the population that has heart failure. If we're saying 15% of these people have ATTR, which is now a treatable condition with many different therapeutic modalities that can be utilized to arrest the disease, or at least slow it down significantly, it is incumbent upon us to then find these patients. We want to be able to identify them. And that's a huge issue right now. So if you report 100 echocardiograms with HFpEF, okay, so there's 100 patients with the HFpEF, I want to know which of these 15 have ATTR so I can start them on treatment. Out of these 15, maybe 5 of them will have clear signs of cardiac amyloid, and I can call it out. But there's going to be 5 to 10 that I just report HFpEF, and that's all I'm reporting. And what do I do with them? like right now, we don't have great guidance on what we do with them. I think most people will say that, well, you know, their clinicians need to be asking them clinical questions about potential amyloid. You know, do they have carpal tunnel syndrome? Do they have spinal stenosis? Are they having signs or symptoms of peripheral neuropathy? So I think some people will be good about asking these questions, but not every patient's even going to have neuropathy. They may have predominantly cardiac disease, which is not yet manifesting. Maybe they have some really subtle shortness of breath, and sure, they're developing a little bit of heart failure, but how do we know they're not part of that 85% that doesn't have ATTR? So there's a lot of, I think, debate right now about how we identify these patients. Should we be ordering cardiac biomarkers? Should we be doing cardiac MRIs on everybody? Should we be doing technetium pyrophosphate scans on everyone? I think that it's wide open right now for debate, but I think one place where AI can really help is if the sensitivity and specificity continues to rise, it can fill that gap between identification of HFpEF and taking it to the next diagnostic step, which would be, you know, for AL, we're talking about tissue biopsies. For ATTR, maybe technetium pyrophosphate scans. But before we pursue another costly diagnostic test, is there some way to risk stratify that is more reliable than asking some of the clinical questions? And so I think that's where imaging and AI within imaging can add value. So I think right now it's still pretty early, but I think that's where I can imagine there being some growth in the diagnostic space. So, you know, before we started using EchoGo amyloidosis, we essentially were not able to see early cases. You know, I am presuming these are early cases that we are finding as positives. Before we were using it, we would rely essentially on our best readers to pick up the disease. So the best of us will detect it based off of mild thickening of the left ventricular wall, you know, reductions in global longitudinal strain. If you see an apical sparing pattern, it's more of a clincher. And, you know, these patients, we would report that, you know, these patients might have amyloidosis, and we would refer them for further evaluation. But when the disease was early, we weren't able to say much. You know, sometimes I would see mild LV wall thickening, but not see anything else really. And so I would mention that, you know, this patient has wall thickening, and I don't really see a history of high blood pressure, and we don't see any other reasons for this. They should be, you know, referred for further evaluation to see if they have some form of an infiltrative disease. But that's really as far as I could take it. Whereas now, I think if the algorithm is able to profile them into the amyloid category, then we have more information to go off of, and we can evaluate these patients. The other thing is, not everybody's looking for amyloid. Okay, so I might be looking for amyloid on every echo. The average practitioner is not looking for amyloid on every study. Even within you know, our center, not everyone is as attuned to this particular condition. And so I've had referrals to my clinic from colleagues who said, you know, I read this echo, and at the end, there's an Ultromics slide that says this patient, you know, this echocardiogram is suggestive of amyloidosis, and could you take a look at them? And so that's new for me. Like, I usually wouldn't have that happen, but where a cardiologist doesn't see any signs of amyloidosis, but they're sending the patient to me because the AI has picked up a signal. And when I look at the echocardiograms, I mean, I'll see a bunch of signs that are concerning to me. And so I think it's doing what a specialist in the space can do, and then it's also doing things that perhaps I cannot do, where there is going to be early signs that essentially AI is going to be a conglomerate of the best of us, and so if it's able to provide that level of expertise in the read, we expect that that's going to improve diagnosis and identification of more patients.